talking about tubular reabsorption and secretion. So tubular reabsorption is when the solutes that get filtered into the tube get reabsorbed into the bloodstream. And you have transcellular, which goes through transporters in the cells, and then you have paracellular, which goes around the leaky tight junctions of the cells of the tube. So you have reabsorption of pretty much everything in the proximal tubule. The biggest thing to note here is sodium reabsorption, because sodium is paired with almost everything to co-transport back into the blood. And the exceptions, the major exceptions to that are hydrogen and chloride. So I like to think of hydrogen and chloride are the opposites. So they have an antiport. So when sodium's reabsorbed, hydrogen and chloride come back in as an antiport. A really important factor here is the sodium-potassium ATPase is really important for the reabsorption in the proximal tubule. And there's also some extrinsic factors that affect the reabsorption here. The sympathetic nervous system affects it. It will increase sodium reabsorption by affecting the alpha-1 receptors. So I think of that correlation with sodium has the A and alpha-1 looks like an A is alpha, so sodium is alpha-1. And then also the sympathetic system affects renin, so it'll increase renin via the beta-1 receptors. Also, angiotensin II affects absorption of sodium with the hydrogen exchanger, the bicarb co-transporter, and also it increases the activity of the sodium-potassium ATPase. You have the glomerular tubular balance, which affects the reabsorption. So the main part of the reabsorption is just concentration gradients here. And also PTH will increase the sodium and phosphate excretion because PTH hates phosphate. So that co-transporter will take it out. And some things are very high capacity for reabsorption here. Water, sodium, chloride, potassium, and bicarb are reabsorbed here. Also, a lot of your larger molecules, your glucose, your amino acids, and your proteins. So those are all reabsorbed here. And then you have some low energy reabsorption. So your apical membrane of the proximal tubule is permeable to water. And also you have leaky tight junctions and solvent drag, which are low energy ways of reabsorbing. So some clinically significant things to note about the proximal tubule is that this is the site of action of CA inhibitors, such as acetazolamide, and those are used for things like glaucoma and altitude sickness. And you know, with altitude sickness, your body goes into a state of alkalosis. So one of the effects of the CA inhibitors is it causes acidosis, so that counteracts the alkalosis. And CA inhibitors also cause diuresis because they're diuretic. And when this part of the tubule has a decreased extracellular fluid, because of the body's extracellular fluid decrease, it will increase sodium uptake. But with the sodium uptake, we know it has a lot of co-transporters, so it will also take up a lot of bicarb. So if you have a low extracellular fluid, you'll take up a lot of sodium and in turn bicarb, and so that can give you a state of metabolic alkalosis. Another thing that is a byproduct of absorption of sodium that can cause a negative effect. If you have increased sodium, you have increased uric acid reabsorption, and this can cause a gouty arthritis attack. So that's when the proximal tubule is working the way it's supposed to. And then over here we have some disorders that would make it wouldn't be working the way it's supposed to. So first I'm going to start with Hartnett disease, and maybe you can't see it, but the AR in Hartnett is underlined because it's an autosomal recessive disease, and it causes a decreased transport of amino acids in the kidneys and the intestines. Most notably is tryptophan. So you have a decreased transport of tryptophan in the intestines and the kidneys. And if you have decreased tryptophan transport, you're also going to have a niacin deficiency. And so Hartnett disease can lead to CNS toxicity. Most people are asymptomatic with this, but some of the symptoms that people can present with pellagra-like skin eruptions, cerebellar ataxia, psychiatric problems, and gross amino acid urea. So those kind of make sense. If you have CNS toxicity, that you would have psychiatric problems and things like that. And then the gross amino acid urea makes sense because if you're not reabsorbing the amino acids, then they're going to be excreted out. So next I want to talk about cystinuria, and this is also an autosomal recessive disorder, and it's when you have a decreased cysteine absorption, and so obviously if it's not being reabsorbed, it's going to be excreted. So the cysteine that's being excreted will cause recurrent renal, ureteral, and bladder stones, and these stones will come up with flat, colorless, hexagonal crystals that look like this. The next disorder I want to talk about is Fanconi syndrome. This is kind of like the mob boss of proximal tubule disorders, because I think Fanconi reminds me of like a mob name. And so really it just dumps everything. So if like you in the mob, you just dump everything into the bay. So it's a decrease in general reabsorption of everything pretty much in the proximal tubule due to a defect in the cellular energy metabolism of the tubule. So you're just dumping everything. You just aren't really reabsorbing everything you need to do. Also, the causes of Fanconi syndrome are kind of like things, idiopathic. So like, the mob tries to hide things. They don't know, so you don't know what they're doing. Drug toxicity, heavy metal poisoning like lead and mercury, multiple myeloma, and the most common cause is cystinosis or inherited. Kind of like, like the mob is inherited from one big boss to the next to the next. So now we'll talk kind of the symptoms that come from Fanconi syndrome. And these are kind of like if you cross the mob, this is what happens to you. So first you'll sleep with the fishes. So you're going to have polydipsia, polyuria, and dehydration. And these all make sense because if you're not reabsorbing all your solutes, your water is going to go out with your solutes. So you'd have dehydration, and then polydipsia because you're thirsty because of the polydipsia, or polyuria. Polyuria makes you thirsty, so polydipsia. And then you'd have major complications with your bones. So you'd have bone abnormalities, growth impairments, and failure to thrive. So you cross the mob, they're going to break your bones, you're going to have failure to thrive. And then lastly, these all make sense. You have hypophosphatemia, hypokalemia, hypocalcemia, and acidosis. And these are because, if you're not absorbing them, obviously your body's going to be low.